Well, I'd like to welcome everyone to the final two sessions of this unique combined conference, collaborations between the Physiological Society and Intensive Care Society. So we've got a fantastic lineup for this session here on underlying conditions and special circumstances. And at the very final session, we'll have a broader group discussion as well. Before I introduce the speakers, there are some housekeeping notes I want to make sure everyone's aware of. First of all, just for the format of the session, we'll have 4 speakers. Each will be giving a 15-minute presentation. And rather than have questions at the end of each presentation, we're going to compile them at the end, and there'll be 25 minutes for us to go through those questions and a discussion with a panel. So if you can please submit your questions through the Q&A button on the right of the video stream. We'll get the questions directed to the panel, and the chair, myself and Dan as well, will be compiling those and putting them to the speakers. Please try and keep submitting them as we go, because if you submit them right at the end, it might be difficult to actually pose those to the speakers. So as they occur to you while you're listening, that'd be great if you could just submit them at that time. And you also have the option to upvote questions. If you would like to submit questions anonymously, you just have to type anonymous before your question. And if not, if you want to include your institution at the beginning of your question, we can announce this with your name as well. We might not have time for all questions, but we will try and get through as many as possible. And please note that the session is being recorded and will be available on demand following the conference. And as we've done throughout the conference, if you want to use the hashtag on Twitter, it's hashtag COVID-19 conference, and you can share your thoughts on Twitter as well. So that's the housekeeping notes done, and I'm just going to move on to present our first speaker. And we're delighted to have Professor Sir Stephen O'Reilly. He's a director of the MRC Metabolic Diseases Unit at the University of Cambridge, and he'll be speaking to us about obesity in the context of COVID.
Thank you. I'm sure you'll let me know if you can't see my screen. It's a real pleasure to be presenting at this conference. I feel a bit of a fraud in that although I've thought and written about this topic a bit, I've done precious little original research, but I thought I might be relevant to share some of my thoughts with you today in this next 15 minutes. What I'll talk about are the following 4 questions. First of all, is obesity associated with the outcomes of COVID? Is it specific to COVID? If so, what are the potential mechanisms and can we do anything about it? So in terms of its association, it started with a flurry of small hospital-based observational reports, all potentially fraught with bias, so-called collider bias, etc. But it was followed up by an increasing number of large population-based studies, the most important probably of which was this very large Open Safely trial reported from colleagues in Oxford, where...
Stephen, sorry to interrupt, Stephen. I think that we can't see your slides at the minute. Do you want to try and share them again? Okay,
I'm sorry, I better... Are you seeing them now?
That's it, perfect, thank you.
Okay, I'm sorry, it's just, okay, if you can see them now, that's fine. Yeah. So in the Open Safely trial, obesity here circled in red was clearly associated with mortality in a large population-based outcome study with a gradation from the lowest level of obesity to the highest. This is very fresh out of the oven data from my colleagues Susan Deuchars and Paul Aviard, work I have contributed a little bit to from the GP records, the Q research, looking at hospital admission, ITU admission, and death. And here we can see actually just as clearly as in the Open Safely, but with data going down to a minimum hospital admission and mortality around a BMI of 23, you can see the progressive increase in hospital admission, ITU admission, and death associated with BMI. Most strikingly, the effect of obesity on these risks was much greater in younger and in Black patients. And if you were over 80, BMI had no impact whatsoever. In this study, we also looked at, if you like, the complications of obesity, the ectopic lipid, if you like, markers of ectopic fat. So not only type 2 diabetes, but pre-diabetes as defined by just subdiabetic levels of hemoglobin A1C and non-alcoholic fatty liver disease, and then mutually correcting for each other. You can see if you correct for the markers of ectopic fat, you still get an increased odds ratio, but it's not very dramatic. It's more driven by these complications of obesity, the markers of ectopic fat. So yes, BMI is associated, but perhaps the suggestion is that it's not BMI itself, it's what it's doing to your metabolism that is having the impact. So is this unique for the lung disease or the disease of SARS associated with SARS-CoV-2? Well, it sort of is in some ways, because certainly with seasonal influenza, obesity was not in a pretty large series, not associated with seasonal with the worse outcomes in seasonal influenza. And as ITU physicians will know about the obesity paradox in general, if you're in an ITU with acute respiratory distress, you don't do worse. You may even do better if you're obese. So there is something a bit specific. It may, of course, there is data on pandemic flu, which is somewhat similar. So maybe there are particular subtypes of viral infection where obesity has its bad impacts. So I hope I've convinced you that obesity does worsen COVID-19 outcomes. How does it do it? How does it influence the risk of getting the virus? Might it have influenced viral behavior once you're infected? Or might it influence the host response to SARS-CoV-2 infection? So I think to get to an answer to those, you really have to ask, what's going on? What's killing people with severe with COVID? And what's the host response to obesity and how they might intersect? I was particularly impressed by Mauro Giacca's paper on 40 consecutive postmortems of patients dying of SARS-CoV-2 with the extensive alveolar damage, lots of thrombosis in the lung microvasculature, no viral RNA in other tissues. And I know there's a lot of emphasis on the extra pulmonary manifestations, but really the dominant feature in these very high quality postmortems was the pulmonary, and particularly the pulmonary microvasculature pathology. The response to DEX indicates that inflammatory factors must be going on, and there's lots of evidence of thromboses, including thromboses in other organs. I'm teaching my grandmother to suck eggs here in this society, but from what I've read, it seems remarkable that many of these patients who are dying have reasonable lung compliance, but very poor oxygenation. Again, bringing us back to this issue of microthrombosis and the alveolar damage in the pathogenesis of this illness. So how might obesity influence this, either the viral behavior or the impact on the organism? Well, will obesity increase your viral exposure? Certainly, obesity is negatively associated with socioeconomic status. And the REACT study does show that low SE status gives you a higher risk of getting the virus. But if you correct for socioeconomic status, there's no evidence that being obese makes you catch more SARS-CoV-2. Theoretically, once it gets into your nasopharynx, there's been suggestions that the increased prevalence of reflux esophagitis in centrally obese individuals could increase aspiration. There are theoretical reasons why the virus invasion and proliferation might be influenced by obesity. Those lipids are directly involved in viral spike protein assembly, and lipid content of the bronchoalveolar lavages from obese patients are more lipid rich. ACE2 expression may be influenced by diet, although the data is really not very compelling or consistent on that. And of course, there are viruses where intracellular lipid droplets are essential to the viral life cycle. And that's a topic of active research at the moment with colleagues in Cambridge and in London. So other possibilities are that we know that obese and ectopically lipid overloaded people have very poor cellular metabolic flexibility. They don't switch rapidly between carbohydrate and lipid oxidation. And of course, viral infection often does induce an intense Warburg effect. So it's again theoretical that a lipid-laden cell may be more prone to viral cytotoxicity. But to really understand what obesity is doing, and one of my hopes today is you'll go away thinking that obesity is more than just a big belly and a heavy chest. you have to really think about what is going on in obesity, which is essentially a state of chronic energy intake more than energy expenditure. And that leads to an increased mass of triglyceride and adipocytes, which we call obesity. Often a term, I think, that leads to brain freeze. It's associated with such pejorative implications that people actually often sometimes find it hard to think logically about it. But you need to think obesity per se, this expanded mass is not a problem. What's a problem is the associated pathologies. And they come in three flavors: the mechanical, if you like, gravitational effects of obesity, associated with cancers, and metabolic and endocrine disorders. Now, it's pretty obvious how the expanded mass of triglycerides can predispose to osteoarthritis of the knees, reflux, etc., narrowing of the airways to cause sleep apnea. But the relationship between this expanded mass and these other outcomes are really not nearly so clear. It's possible that it's directly contributing, but it's also possible that it's just simply a biomarker for the fact that chronic intake over expenditure is the real problem, leading to a metabolic state that predisposes to these conditions. Now, one of the earliest things that happens to people who become obese, or as BMI increases, is that you raise your level of fasting insulin, and indeed your insulin throughout the day, in a state of insulin resistance / hyperinsulinemia. The body perceives that insulin does not work to control blood glucose, so the pancreas compensates for that by producing hyperinsulinemia. And that is one of the earliest and most sensitive markers of the metabolic disturbance of obesity. And of course, it varies enormously between individuals in terms of the severity, but it's very consistent relationship across BMI. How does that happen? How do we get from sustained positive energy balance to this defective glucose handling in liver and muscle? Well, if you asked 100 diabetologists at the moment, they'd say it's all the big bad fat cell. We know that we have inflammation in fat, these excessive adipocytokines, we have reduced adiponectin, and they somehow, by rather magical means, lead to this defective glucose handling in liver and muscle. But you may surprise you by saying that I'm not a great fan of this hypothesis. It's very strongly supported by animal work, but neither human genetics nor human pharmacology really provide very strong support for this mechanism. I'd like to bring your attention to a more old-fashioned view of the adverse effects of sustained positive energy balance. And that is that your big fat cell is not your enemy, it's your friend. It's by far the safest place to keep this sustained positive energy balance. And you only start running into trouble when you're unable to safely store positive energy balance in adipocytes. And you then start, and when you start reaching the safe limits of storage, you start to put ectopic fat in the non-professional macronutrients storage tissues such as liver, skeletal muscle, vascular endothelium, etc. Now, there's no doubt that inflammation does accompany the accretion of fat mass. And as you get fatter, there's no doubt that you see an increased macrophage entry into adipose tissue. And here they are, as a beautiful picture of these so-called crown-like structures. But really, they're doing their job. They're actually coming in to digest dead and dying overstressed fat cells. Somehow blaming them for all the ills of obesity is a bit like blaming vultures in a battle scene who have come in to clear the corpses and blaming them for the mayhem of the battle. So you do get an increased macrophage infiltration, you do get an increased circulating cytokines, but whether they're contributing to the adverse consequences of obesity is not yet certain. In some ways, I favor this following rather simple model, which I found useful in talking to patients. It's that you maintain metabolic health, even if you leave your tap on and your bath plug out, as long as you have a bath that can store your stored triglyceride, and everything is hunky-dory. We usually think about obesity in terms of eating too much, increased energy expenditure, or not expending enough energy. And of course, they lead to the nasty situation of overfilling your bath and ending up with a horrible, soggy bathroom floor. But of course, what we don't often think enough about, I think, is the fact that we're not all born with the same size bath. Individuals have very varied abilities to store adipose tissue, triglycerides in adipose storage. And some individuals, even at a small imbalance between intake and expenditure, develop severe insulin resistance and then develop the ectopic lipid in muscle and liver. And work we did with Nick Wareham's Institute a few years ago really provided the molecular basis for this concept. And those of you who are interested should have a look at this paper, because really they show that the genetic determinants of insulin resistance in the general population are very focused on adipocyte genes that determine the health of triglyceride storage within the adipose depot. So how does to bring these together, can we get a picture of what we think is going on in the lung? And I'm not apologizing for focusing on the lung, because I think that's where the majority of the fatal pathology occurs. So how can obesity worsen the outcome of the exposure of the alveolus to these viruses? Well, let's take it through in various steps. I mentioned to you that yes, obesity is an inflammatory state. There are increased levels of IL-6, TNF, and IL-1 beta circulating in people with obesity. And we know, and we certainly know from the fact that immunosuppression does have a beneficial effect on the outcomes of COVID, that this could exacerbate the inflammatory state that is harmful, or the hyperinflammatory state. You may not be as familiar with the adipocyte-specific protein adiponectin. Adiponectin has been around for about 20 years. In fact, it's so specific for adipocytes, it's used as the driver to tissue specifically express genes in adipocytes in mice. So it's a really well-known gene for the metabolic community. And it's very strongly associated with insulin resistance and body mass index. But paradoxically, it's much lower if you're obese or insulin resistant. So you get reduced levels of this fat-specific protein adiponectin. Could this be possibly relevant? We've struggled for nearly 20 years to find consistent metabolic effects of adiponectin, but a new literature is emerging, and a literature that suggests that adiponectin is an anti-inflammatory and quite a powerful anti-inflammatory agent. Here's one such paper that relates it to the pulmonary vasculature, for example. There's high expression of T-cadherin, one of the receptors for adiponectin on the surface of pulmonary epithelial cells. Here are some examples. E-selectin, which pulls neutrophils in states of inflammation onto endothelial membranes. If you expose pulmonary arterial endothelial cells to TNF, you see a marked increase in E-selectin. And this is markedly reduced by exposure to adiponectin. So obesity is a state of adiponectin deficiency, and we know adiponectin can have very profound effects on the pulmonary vasculature. So I think that this is a really potentially potent area for cross-disciplinary research in the area of why obesity is worsening COVID. Another feature of COVID pathology is the profound deposition of complement components, and many distinguished colleagues of mine, including my old boss Keith Peters in Cambridge, are convinced that that interference with the complement pathway will be one of the most powerful ways of preventing the progression of severe COVID pathology. And obesity is a state of hypercomplementemia. Here are individuals with various levels of obesity, and then subjected to just a 6-week diet. And you can see that increasing obesity is associated with increasing levels of C3 in particular, no effect on C4, but the diet, even a 6-week diet, is enough to prevent this increase in complement. So again, there's a link here between obesity and one of the powerful inflammatory mediators of the COVID pathology. Moving on to the ectopic lipid in both muscle, shown here in liver, but also in skeletal muscle. This leads to insulin resistance and hyperinsulinemia, and these are well known to impact on both endothelium and indeed in platelets, and to increase the plasminogen activator inhibitor as to reduce fibrinolysis. So all of which would tend to promote thrombosis within the pulmonary microvasculature. And those of you who maybe think that fatty lung is not a real thing, and certainly it's very poorly described in humans, there's some pretty compelling rodent data that in severe models of obesity in rodents, you can get very marked alterations in alveolar structures and surfactant protein in the alveolus. And this in particular affects the type 2 pneumocytes, which are the target cell for the SARS-CoV-2 virus. So, interesting aside, at the same level of body fat, insulin resistance is considerably higher in men than in women. Is this potentially relevant for the male sex-specific predisposition to do badly with COVID? it's also higher in South Asian origins than in most other Asian groups. And the same is true in people of African descent, that hyperinsulinemia, although not ectopic lipid, is higher in people of African origin than in white Europeans. Is this relevant to therapy? Well, clearly we can reduce the adipose mass and we can reduce the ectopic lipid by caloric restriction and physical activity. But what's important to point out is this takes a long time to reduce the amount and mass of adipose tissue, but can within days improve insulin sensitivity. So even modest amounts of caloric restriction and physical activity can have profound effects on some of these mediators of the metabolic complications of obesity, and thereby potentially on the COVID severity mediators. There are also, of course, drugs independent of caloric restriction and physical activity that can improve insulin resistance and hyperinsulinemia, metformin, the thiazolidinediones, SGLT2 inhibitors. So I would like to suggest some at least testable hypotheses that it's, first of all, it's metabolic syndrome rather than obesity per se, which impacts adversely on COVID outcomes. This should be testable by Mendelian randomization, where we can compare genetic risk scores versus insulin resistance risk scores. A word of extreme caution, though. To see things, you need a very good telescope. We've got a fabulous telescope for obesity genetic risk scores. We've got a much weaker telescope for these metabolic scores. So if we see nothing, it could be quite dangerous, implying that it's got to be the obesity and not the insulin resistance. We've got to get our tools as good as possible to be able to do proper comparison by Mendelian randomization. Trials of diet and physical activity, of course, and randomized controlled trials of insulin sensitizing drugs would be excellent. If we wanted to specifically test the adiponectin hypothesis, we could do so genetically, but we should point out that thiazolidinediones particularly have a profound effect on increasing circulating adiponectin, increasing it by over 3-fold often after a single dose. So there may be, at least theoretically, a potential benefit, or at least worth considering the use of these somewhat neglected insulin sensitizing drugs, pioglitazone, etc., in this circumstance. So in type 2 diabetes, again, it may be worth considering improving glycemic control with thiazolidinediones rather than with other drugs. And although I'm nervous about showing you this slide because I don't want this to necessarily change clinical practice, because it shouldn't, but this is a paper in Press in the decent journal Cell Metabolism. It is a retrospective study from Wuhan in China, trying to correct as best as possible for all the pre-existing morbid factors and looking at the mortality in type 2 diabetes in individuals not treated with insulin versus those treated with insulin. So it is important at least to realize that although hyperglycemia is important to correct, we're not entirely sure yet whether doing so by, at least by creating pathological hyperinsulinemia is a good idea under these circumstances. So take-home messages on this: obesity is definitely associated with the worst outcomes of COVID-19, more so than with most other respiratory infections. It's more likely to be the effect of metabolic effects than any mechanical effects of too much fat mass. That's good news, because even a small amount of weight loss can improve metabolism before it has any major impact on fat mass. So if I'm talking to any politicians or any people with public health policy, I say, use the phrase, lose a pound, walk a mile. Both of those, exercise, modest amount of exercise, modest amount of weight loss, can have an important effect on insulin sensitivity. And we should really also, I think, be looking to trial drugs that rapidly improve the metabolic state of obese, insulin-resistant people. So thank you for your attention, and I look forward to having questions later.
Thank you very much, Sir Stephen. Hopefully you can all see me. For anyone who joined late, this is the underlying conditions and special circumstances session and we've just heard Sir Stephen O'Reilly speaking about obesity and COVID. We're going to move on now. My name's Dan Martin, for those of you who've not met me before. I work at the University of Plymouth and the Royal Free Hospital in London. And it gives me great pleasure to introduce the next speaker, who I've known for many years due to our common love of high altitude medicine. I'd like to introduce Dr. Kenneth Bailey from the University of Edinburgh, who is going to talk about genetics and COVID. And I think we're all hoping that he's going to discuss with us the findings of his new paper that was published this week. So thank you very much, Kenny.
Well, thanks very much indeed, Dan, and it's a great pleasure to speak at this meeting. And sadly, I have no slides at all on high altitude medicine. The topic is indeed the genetic work that we've done in COVID, and I'd like to start by explaining why we thought it would be a good idea to look in the genome, and then I'll tell you what we found and what we think it might mean. The reason for looking in the genome for answers broadly in critical care medicine is that your chance of dying from an infection is very strongly encoded in your genes. And the nicest demonstration for that I've seen is from this beautiful adoption study from 1988 in Scandinavia, where the investigators looked at people who were adopted and then asked, how did their parents' cause of death impact the child's cause of death? So, for example, if your parents died of cardiovascular disease, what impact did that have on your chance of dying of cardiovascular disease? And of course, because the kids were adopted, they were able to separate out the effect of the adoptive parents and the biological parents, so an index of environmental and biological risk. And the adopted parents are in blue. So these are people that brought the children up. So something about the way they brought those children up increased their chance of dying of cardiovascular disease threefold compared to the rest of the population. And for biological parent, if you had a biological parent who died young of cardiovascular disease, then you're about 4.5 times more likely to die of a heart attack or a stroke yourself. For cancer, the numbers are reversed, and the impact of the environment you were brought up in is substantially greater. So for an adoptive parent dying of cancer, you're about 5 times more likely to die of cancer yourself, and the relative risk for having a biological parent who died of cancer is 1.4. For infectious diseases, that's any infectious disease in the whole study, the numbers are very striking. So if you're adopted and your biological parent, sorry, and my slides have failed, so I'll just, there we go. So if your biological parent died young of any infection, then you're about 6 times more likely to die of an infection yourself. Whereas if your adoptive parent, the person you called mum or dad, who probably coughed on you during their final illness, died young of an infection, then you're almost no more likely than anyone else in the population to die of an infection yourself. And this makes sense in the context of our evolution. Infectious diseases have been a very profound selection pressure on human populations and the populations of our ancestors way before we became human. The reason that we want to find the specific points in the DNA that alter your probability of dying of an infection or sepsis, or even the other syndromes that we treat in critical illness like trauma, burns, pancreatitis, is that the genetic findings, the specific genes that we find, might lead us to new treatments. They might help us to understand the biological events that are occurring in our patients during critical illness in ways that will lead us to drugs or other tools that we can use to modify those biological events in order to promote survival. So in 2015, we started the genomic study, Genetics of Mortality in Critical Care. And really the aim is to study these syndromes that we're all very familiar with treating in the intensive care unit in order to better understand the underlying biology. And from the point of view of infection, clearly, sepsis makes up a very large proportion of our workload, but for every infection that we see, it's by definition the most severe cases that we see in intensive care, and they're the patients who are by definition most susceptible and the ones in whom we'd expect to see the strongest genetic signals. So it absolutely makes sense for this work to be led from the critical care community. And it's a worldwide study. The study is designed so that anyone can copy it and use not just the approach, but actually the protocol and consent documentation. Even our website and sample tracking systems are all openly available to anyone who wants to replicate the study elsewhere. And of course, the reason we've done that is that in order to study the rare syndromes that we're interested in, we need very large numbers of patients. And the only way that we're going to achieve that is to recruit both over a very large area and for a very long time. the very first inclusion criteria that we wrote for the study was critical illness caused by SARS or MERS or Ebola or other emerging infections. So this has been a study of COVID since before COVID existed. And we're very fortunate in the UK to have not just an extremely cohesive and effective community of critical care researchers across the whole nation, but also the National Institute for Healthcare Research, the Chief Scientist Office, and a huge population genetics study called UK Biobank that gives us a great idea of the genetics of our population so that we can compare critically ill cases with them. And we're very pleased to be working with Genomics England and the NHR Bioresource to deliver this work now. So the population of patients that we've studied is critically ill adults in intensive care units across the whole UK. And I'm going to tell you the results that we've got for COVID. We do have other syndromes, of course, the numbers are accumulating, but not enough yet to make genome-wide discoveries. We need literally thousands of patients with the same disease in order to find significant signals we can be confident about. The group of patients that we're talking about are COVID patients who fall into a subgroup that probably have important biological differences from all hospitalized COVID patients and certainly all patients who have COVID in the community. And the best evidence for this is the recovery trial result for dexamethasone. So here's the forest plot stratifying the hospitalized population into those who needed invasive ventilation, those who needed oxygen, and those who didn't get oxygen but were for some reason admitted to hospital with COVID. And so recruited into the trial. And you can see that the benefit of dexamethasone is strikingly greater among patients who are already on mechanical ventilation at the time they were recruited into the study. So there is modifiable inflammatory lung injury in these patients at the time that they were recruited in, and they have a different response to steroids from other subgroups of patients. And they're the group of patients that we recruited into genomics. So we're very much focusing on the genes that not only determine your risk of catching the virus, of allowing the virus to replicate in your body, but also of this later syndrome of life-threatening lung inflammation developing. So here's what we found. This is it's called a Miami plot. The spikes indicate the signals are meant to look like buildings, and the Miami comes from the reflection in the water of the buildings on the coast. The y-axis shows going upwards, the p-value in the genomic study, and actually it's negative log p-value, so higher is stronger signal, for every one of 5 million variants across the whole human genome that we looked at, and they're just lined up by chromosome. And I've highlighted the ones that we have convincingly associated with susceptibility to life-threatening critical illness in COVID. The lower part of the graph shows essentially everything that we know now about critical illness in COVID from a meta-analysis of not just the genomic study, but also several other studies, combined population genetic studies like UK Biobank, where we already have the DNA for the patients, we already have their whole genome genotyping, and over time some of them have been admitted to hospital, and the population genetic studies have recorded that all around the world, and the numbers are increasing. They're not on the scale that genomic is yet, but they've been increasing, of course, as the outbreak continues. And finally, a study led by the direct-to-consumer genetics company 23andMe, who kindly donated their data so that we could meta-analyze it. And you can see that in most cases the signals are present, and in one case they get quite a lot bigger. So there is probably a signal here at the ABO locus, the ABO blood type locus, which hasn't quite met statistical significance, but when we add everything together, it's heading in that direction. So of these, this one was known before. This is a very, very strong genetic effect on chromosome 3. It was reported in the New England Journal a few months ago. So I'm going to focus on what's new, and particularly these 4 variants along here on chromosomes 12, 19, and 21 that are all new discoveries from the Genomic Project, and all have potential therapeutic relevance because, by luck, they're all near genes that we know something about. We understand a bit of the biology here. So I'll focus on a couple by zooming in on those areas. So again, this is a y-axis showing negative log p-values. So for each variant of the genome, the higher is a stronger signal. And down here you can see protein coding genes that are present at this area of chromosome 21. So this signal we think is relating to this gene, IFNAR2. This is the interferon alpha beta receptor subunit 2. I think if you were to ask anyone what bits of biology are important in viral infection, interferon was discovered in 1957 and since then has been the canonical signaling molecule of the immune response to viruses. And there are examples of people with broken interferon signaling systems because of single gene defects, who are more susceptible to viruses like flu and many other viruses. So we knew this system was important, but we didn't know it was important in COVID. Our data suggest that the amount of this receptor that you produce alters your probability of becoming sick with COVID. So we use Mendelian randomization, which was mentioned in the last talk, which is a technique where you take a genetic variant that changes the amount of a mediator you produce or another factor, and ask the question, if I make more or less of that mediator, what does that do to my chance of developing critical illness in COVID? So for interferon alpha, we can say if you have this variant, you're likely to produce more interferon alpha beta receptor subunit 2, suggesting that more interferon signaling is received by your cells. And if that was the case, you were protected from COVID. So more interferon was, by that evidence, beneficial, which would suggest that treating with exogenous interferon would be expected to confer a therapeutic benefit. Now we know from the Solidarity trial that subcutaneous interferon among hospitalized patients did not improve mortality, which I think leaves two possibilities that are very plausible. One is that a different route of administration might be effective. The other, which I think is consistent with what we're seeing for the effect signal for remdesivir and other antivirals, is that treating earlier in illness is more likely to be effective because that's when the viral loads are high. And when we meet the patients in hospital or certainly in intensive care, immune-mediated lung inflammation is the problem, and treating the virus hasn't had a big impact at that point. Very briefly, this other group of genes, OAS1, 2, and 3, encode an interferon-inducible system that activates an enzyme called RNase L, which degrades viral RNAs. So it directly binds to and destroys the viral RNAs and stops the virus from replicating. So this is a host antiviral mechanism. Interestingly, this is potentially druggable. There's a class of drugs called phosphodiesterase 12 inhibitors, which are in development that increase the signaling through this pathway and increase the activation of RNase L. And this evidence suggests that this is important in COVID. It's probably not important in other coronaviruses. Other coronaviruses have methods to interfere with this system and inhibit your own host antiviral response. But SARS-CoV-2 is not known to have that ability. So it could be that this is a useful therapeutic target. And finally, this complicated area encodes a lot of genes that might have an impact on inflammation, but in particular, this gene, tyrosine kinase 2, we showed, again, using Mendelian randomization, that if you produce more tyrosine kinase 2, you're more at risk of COVID, suggesting that inhibiting tyrosine kinase 2 is likely to be beneficial. Now, we don't know that that's the case. There are several caveats here. The genetic effect might be mediated through a different gene, or it could be that it doesn't matter how much of the tyrosine kinase 2 you produce, but rather that coding variants within tyrosine kinase 2 are what matters, and we haven't detected those in this study. But from our evidence, it's very interesting that this signal is opposite to interferon, because interferon signaling does increase tyrosine kinase 2 signal. So our evidence suggests that more interferon signaling and less tyrosine kinase 2 signaling is what you want. So you want to inhibit tyrosine kinase 2. Now, that's very interesting because there's a class of drugs called JAK inhibitors, of which an example is baricitinib, that have this effect. They inhibit tyrosine kinase 2, among other enzymes. And they've already been proposed for use in COVID, and there are some trials that suggest a trend towards reduced mortality. We also looked across the entire genome for these expression signals where more or less of a gene has an effect. And we found several significant associations in lung. They're highlighted in red here. The one I'd like to draw your attention to is CCR2, the chemokine receptor 2. which is the receptor for a mediator called monocyte chemoattractant protein, which is a very striking finding because infiltration of monocytes, as we heard in the last talk, into the pulmonary vasculature might well be a key mechanism in COVID. We now have 6,788 patients recruited into the study. That is a consequence of a tremendous amount of hard work by a very large number of people. I would like to acknowledge, obviously, the 5 joint first authors on the paper that we've just published. It came out in Nature last week, who did a tremendous amount of work very, very fast to make these results available. And also mainly the UK community who recruited the patients into this study. So there are 1,400 people across the UK who have worked to recruit patients across almost every intensive care unit in the UK. I can't obviously thank them all, and there's no point in listing all their names here, but they're all listed as co-authors in the paper. And in the last 2 weeks, these are the top recruiting sites. Obviously, we're extremely grateful to all of them. I'll be happy to take questions in the discussion session. Thank you.
Thanks, Kay, for a really great overview. And I'm sure there'll be lots of questions as well in the final session. I'm now going to move on. We're really pleased indeed to have Pratima Chowdhury, Professor Chowdhury. So she's a consultant hematologist and centre director for the Haemophilia Centre at the Royal Free Hospital. And she's also Professor of Haemophilia and Hemostasis at UCL. So she's going to be talking on COVID coagulopathy and does it require treatment.
Thanks very much, Naz, for the introduction, and also to Dan for inviting me to be part of this group. I am more of a hemophilia and coagulation doctor, and we do work closely with the intensivists, but it's a bit of a novelty for us to be in an intensive care meeting. And I think this is a particularly challenging topic, and I think it's particularly challenging because within our own department, we don't have a consensus, and therein, so it will be a very personal view of what I think is happening or not happening. So in terms of the first question is, should we define COVID coagulopathy? I mean, as a general thing in hematology or hemostasis, we would say that a coagulopathy is present if there is an alteration in coagulation secondary to a multisystem disorder. We kind of specifically use it for multisystem disorder. And typically we ask that there is at least one or more than one abnormality in your routine tests of blood coagulation. That is your prothrombin time, your activated partial thromboplastin time, your fibrinogen and D-dimers. Typically, what we tend to see in intensive care patients is DIC, whether it is overt or a kind of a non-overt DIC. And DIC is very much a consumptive coagulopathy, wherein you see a prolongation of your prothrombin time, you see a prolongation of your ABTT, you see an increase in D-dimers, but you also see a decrease in fibrinogen. And I think very early on, the one thing we picked up on COVID coagulopathy was that the increase in D-dimers was disproportionate to any prolongation of prothrombin time, but also there was simultaneously a marked increase in fibrinogen. And I think the general feeling amongst most of the, at least within the unit, was this is very much an inflammatory coagulopathy. What is it that is driving this inflammation? I think most of you all are familiar with these multiple diagrams, which kind of show in terms of your the microthrombi, which have been mentioned, and also in terms of your hyaline membranes within the alveoli. I think for me, I think the major challenge for me today would be is to convince all of y'all that the coagulopathy of COVID is just not intravascular, but it is also extravascular intraalveolar coagulopathy. So if we think in terms of the intravascular changes, I think we all have acknowledged in the last few months that there is endothelial activation. And I think if you have endothelial activation, it closely follows coagulation activation. I think there is impaired fibrinolysis because of an increase in PI1, and there are several other systemic disorders that seem to worsen this increase in impairment of fibrinolysis. The net result is that there is a microthrombus in pulmonary vessels. For most intensive care physicians, this is not. This is the norm. You're aware that this is quite common occurrence in patients with ARDS and also in patients with other kinds of ARDS pathology. But what about the extravascular or the intraalveolar coagulation? I think we know that the alveolar epithelium is damaged. That happens in all ARDS, but we also know that this epithelium is able to support coagulation. And I think the coagulation proteins, some of them are intraalveolar, but also you have plasma that is leaking into the alveoli. And I think the intraalveolar coagulation has been demonstrated by many groups. Again, I think there is impaired fibrinolysis. And essentially what you have is the formation of what we would call as an alveolar clot or an alveolar fibrin clot that is quite rich in fibrin. So the challenge for us is, which are we going to treat? Is it important for us to treat the thrombus in the pulmonary vessels, or are we going to address the clot in the alveoli? So I think I'm just going to kind of quickly do an overview of the pulmonary thrombi. And I think one of the things we have learned is that a consequence of the coagulation activation, particularly the intravascular coagulation, has been an excess of pulmonary embolism. And I think there are several meta-analyses that have been published, but the one that I've chosen was done in September. And this shows that it may be anything between about 13.5 to about 22.7%, depending upon whether you're just looking at pulmonary embolism or pulmonary embolism and deep vein thrombosis. Within this context, I just want to share some experience from the roll-free. I think one of our consultants actually maintained a database of about 1,000 patients walking through A&E. And I think we introduced D-dimers at the tail end of March to say that, I think this was the time when there was a lot of concern or the association between elevated D-dimers and mortality, and if there was something else we needed to do for this group of patients. So what we found was that along with the increase in the uptake of D-dimers, there was a little bit more of focus in terms of evaluating the patient's symptoms. And bottom line, about 10% of the patients received a CTPA within 48 hours of attendance to A&E. And what we found is that in this group of patients, I think the PE was seen in about 37%. But I think what's important is if the D-dimers were more than 5,000 nanogram per mil, this increased to about 62%. I think we also looked at our ICU cohort, and what we have noticed is that the prevalence of pulmonary embolism increases with the duration of illness. So again, I think this is just a summary of the many publications that have come in terms of what are the coagulation changes we see. I think universally we see increased amount of tissue factor expression that is just related to cell damage and also activation of monocytes. There's increase in terms of factor VIII and von Willebrand factor and fibrinogen. All three of them are acute phase proteins. We know there is contact pathway activation. Again, there is an element of platelet activation. On the endothelial side, we know that if the endothelium is damaged, you lose your normal anticoagulant surface. So there is a shedding of thrombomodulin. There is loss of tissue factor pathway inhibitor. There is shedding of endothelial protein C receptor. So these are all consequences of your endothelial damage. And we also know that there is inhibition of fibrinolysis with increase in PI1 levels. So I think all of these changes can be seen in patients with any other patients admitted into intensive care with abnormalities of coagulation. So the question is, what is it that is unique about COVID that there is such a high amount of D-dimer elevation, which is disproportionate to the rest of the changes? I think this, to me, to most of us, this was the first publication that kind of illustrated the fact that the infection of the COVID virus essentially also is infecting the endothelial cells, suggesting it's just not an inflammation of the alveolar cells, but there is an active damage of the endothelial cells. And perhaps this is responsible for the disproportionate elevation in terms of the D-dimers. I think this was closely followed by this very elegant autopsy study that was published in NEJM in July, where they've essentially demonstrated extensive microthrombi formation in the pulmonary vasculature. I think they had 7 patients who died because of respiratory failure with influenza, and had 7 patients because of COVID. And what you can see is the numerous microthrombi, which are these black arrowheads, and also the expansion of the membrane. But I think what they also pointed out, and I think this is quite elegant, is the fact that the amount of capillary microthrombi were about 9 times more prevalent in COVID-19 patients compared to the influenza patients. With influenza patients, most of the thrombi were seen in the post-capillary venous thrombi, whereas most of the thrombi that were seen, again, within the COVID were within the capillaries. And again, they demonstrated the viral inclusions within the endothelium, suggesting that endothelial infection is part and parcel of the COVID-19 pathology and probably contributing to the significant elevation of D dimers and also the microthrombi formation. So I think if we then move on to the kind of what we would call as the extravascular coagulation or the intraalveolar coagulation, I think for most of y'all, this is well known. I think we know that the fibrin deposition is localized to the alveoli. And this is a characteristic feature of lung injury and repair. This is not new for all of you. This is part and parcel of your daily practice. We know that fibrin deposition is necessary if you're going to restore the alveolar capillary barrier. And I think what again, as I mentioned before, is that as soon as you have damage, you have a procoagulant response, and you also have an impaired fibrinolytic response. Again, it's about the overexpression of tissue factor. There is excess amount of procoagulants now present in the plasma because there is a disrupted barrier that is leaking the factor 7 and also the factor 10. But also there's an increase in fibrinogen concentration via the plasma as well. And the inhibition of fibrinolysis is related to an increased expression of PI1. I think typically, there is a distinction in terms of the amount of elevation of PI1 that you can see between your hypoinflammatory and hyperinflammatory ARDS. And the PI1 levels that are seen in COVID are more in line with the hyperinflammatory ARDS. Again, there is also decreased expression of the urokinase plasminogen activator. And this expression is very important for the alveoli to clear the fibrin that has been deposited within secondary to the inflammation. So I think the question is there any, what is so different about the COVID ARDS? I think the first thing we've said is that there is infection of the endothelial cells. And I think the second thing is there seems to be an excessive amount of fibrin deposition in COVID ARDS. I think this was a paper that was published in 2005, where they demonstrated that there is an upregulation of the messenger RNA expression across the entire alveolar lining and also in the bronchioles. And we know that if there is an excess amount of accumulation of fibrin, that results in inactivation of surfactant. But from a coagulation perspective, what we know is that if there is more amount of fibrinogen, that increases the clot density. And as soon as you increase the clot density, it becomes resistant to lysis. And therefore, I think what we then have is you have an excess fibrinogen that is now resistant to lysis, but you're essentially going to overwhelm the existing clearance mechanisms. And your existing clearance mechanisms within the alveoli, your macrophages. So I think what you then have is that inadequate clearance sets the response for a fibrotic reaction. And I think that is something that has again been demonstrated in this autopsy study from the Lille group in France, where they have essentially said that they could see fibrin balls. And these fibrin balls, yes, can be seen in other groups of patients, but this was seen quite early in the disease when the patients were actually kind of where there was inadequate response. And again, I think most of us would have seen, if you do a CT scan for a patient who has been in ICU for about 4 to 6 weeks, you can kind of see some amount of bronchiectatic pattern, suggesting that there is quite an early establishment of a fibrotic response. So I think if we have to summarize the evidence to kind of answer the question, are we going to treat coagulopathy or not? I think we are quite confident now that there is endothelial damage. It's just not endothelial activation. There seems to be damage in a subset of patients. This is resulting in increased D dimers and increased amount of pulmonary thrombi, both in the small vessels and in the large vessels. The procoagulant and anticoagulant systems are relatively unaffected when compared to other ICU patients. Yes, there are disturbances, but actually they are less than what we are used to seeing in your much more sicker ICU patients. The elevated D dimers appear to be related to the disease severity, and therefore they seem to be a marker for mortality. For the moment, we have said that standard thromboprophylaxis is good enough for prevention of venous thromboembolism. But I think what we've also learned that it's not a bad idea to actively screen patients for large vessel thrombi. I think that a high degree of clinical suspicion with the worsening hypoxemia would merit a CT scan. Similarly, if the patients have got very elevated D dimers, then I think it's very reasonable to do a CT scan, because the demonstration of a large vessel thrombus changes the management of that patient. So the question now is in terms of the treatment strategies. What about the vascular thrombi and the alveolar thrombi? If you look at the vascular thrombi, I think traditionally for any kind of blood vessel thrombus, you would say, shall we decrease the risk of thrombus formation? And typically in COVID, we are trying to decrease the inflammation and the cell damage, and therefore it should result in a reduction in the amount of thrombi. Will the prophylactic use of anticoagulants or antiplatelets decrease the risk of thrombus formation? Once a thrombus has formed, how are we going to decrease the thrombus burden? Is it more about therapeutic anticoagulation, or should we be doing something more active like thrombolysis? And with regards to alveolar thrombi, should we at all attempt to decrease the clot burden within the alveoli by using anticoagulation or thrombolysis strategies? So I think, again, in terms of what are the benefits that we want when we employ such strategies? Is it about a decreased need for oxygen support and ventilation? Are we trying to decrease the symptomatic venous and arterial thrombotic events, or is it an overall decrease in mortality? And all three of them are valid endpoints. And if we look at the studies on clinical trial graph, different studies actually choose a different endpoints. The bigger question that we are yet to address is what is the right point for treatment? Should we be doing it at the first time of diagnosis or at the first sign of a D-dimer elevation, because it is a marker of quite marked endothelial damage and / activation? Should we be doing it in ambulatory high-risk patients, or should we be doing it in hospitalized patients? And this is very important because once the patient is hospitalized and there is already a significant amount of thrombus burden, the challenge for us is the anticoagulation only prevents propagation, but does not result in clot resolution. So all thrombi have to undergo endogenous lysis. So in the context of inflammation, endogenous lysis is always slightly impaired. So this is just a list of the trials. And I think the challenge for us with anticoagulant trials is they are easy to do. So I think when I accessed the clinicaltrials.gov website on the 14th, there were about 59 studies. And when I accessed it much more recently, it had almost gone up by about 30%. There's just a few trials of antiplatelets that I found. And then if we look at something for inhaled anticoagulant trials, which was the other one modality we talked about, there are about 4 registered trials on the website, I think currently recruiting. I'm also aware that there was a proposal to do a nebulized heparin study on the Accord platform within the UK. I'm not aware of the results, and there was another protocol published for a study in Spain. So I'm going to touch on something a little bit more controversial, which is to do with, should we be actually actively trying to break down the clot? If we believe that the thrombus formation is an inflammatory thrombus and has got an origin of underlying inflammation, then anticoagulation sometimes may not be adequate to result in a spontaneous lysis. So within this context, we would typically do fibrinolysis if we think that patients have got a significant burden or it is a critical burden, and therefore we want to have rapid restoration of flow. So there have been 2 studies in the US that are looking at intravenous fibrinolytic therapy. I think about 10 sites with 2 different studies. Again, I think they have published some of their preliminary data on about 4 patients before their phase 2 study started. And what they have demonstrated is that the PF ratio normalizes very early. By about 48 hours in a percentage of the patients, the PF ratio is coming into the normal range. But what they have struggled is to maintain the normalization of the PF ratio. Again, the other study that has currently we are doing at the free is to do with the using a tissue plasminogen activator as a nebulized form with a view to breaking down the alveolar clot and whether that would actually help in terms of improving the oxygenation and potentially the PF ratio. This is the evidence base for the nebulized tissue plasminogen activator. It has, I think there are almost 1,000 mice have been experimented upon to see if this is a safe modality of delivery. It is established in pediatrics for a rare disorder called plastic bronchitis. And in fact, there was a small study that was done in Egypt with the streptokinase that shows that it has some benefit. So I think to go back to the first question, I think, yes, of course, it does require treatment because we do think that it is actually adding to the morbidity and mortality of this group of patients. But I think the challenge is whether we have got the right strategies. So as I kind of mentioned, anticoagulation and antiplatelet agents may reduce the microvascular thrombus burden, but experience has shown us that if you have a thrombus in the context of an inflamed blood vessel, then traditional anticoagulation may not be good enough. Thrombolysis, I think the preliminary studies are very promising, particularly for the intravenous thrombolysis. Again, I think the studies are currently recruiting, but I think the challenge for any intravenous thrombolysis is the risk of bleeding for a patient who is in intensive care. Again, I think what we know is that there are marked changes in the intraalveolar coagulation that seem to slightly differentiate COVID from your typical ARDS in that there is less amount of fluid, more amount of fibrinogen, and also there seems to be more amount of endothelial damage. And I think the challenge of any kind of inhaled route is understanding how it would affect and also monitoring the effect. Whilst it is challenging to address, the question is, does it allow delivery of drug to the site of pathology, and also whether we need to kind of consider more amount of studies. Thank you for your attention. I'm going to happy to take questions at the end of this block.
Thank you very much indeed, Pratima. We are running over time a bit, but for once that's actually not a problem because we have the luxury of another session after this, which we can spill into. So please make sure you use the button on the right-hand side of the screen to submit questions that we can ask the panel of speakers at the end of this session. So I'm going to move on now and introduce the fourth and final speaker in this session, who is Dr. Nazima Patan from the University of Cambridge. And she's going to talk to us today about outcomes in children with COVID-19. So thank you very much, Nazima.
Thank you very much, Daniel. Thanks for inviting me to talk about children in COVID. I'm an intensivist and researcher based at University of Cambridge. And one of the most obvious things is that the vast majority of children do not suffer severe illness from infection from SARS-CoV-2, and the prevalence is estimated to be 1 to 2% in reports worldwide. And the reasons for their resilience to severe illness are something that potentially has an interest for therapeutic and understanding why most children don't get very sick. However, in those that do, very often they present with a different pattern of illness that's more heterogeneous, and often some weeks after the acute infection with the virus. And whilst survival is generally very good, even in those who are most severely ill, there is potentially an impact on their long-term health, and that needs to be better understood in children with their developing brains. So in terms of understanding what is the burden of disease, just first of all going to start with a very important paper from Kenny Bailey's team, the ARDS study, which is probably the biggest UK report of hospitalised children as a subset of the ARDS study, where they reported 651 children and young people under the age of 19, and those with a positive diagnosis of infection with COVID-19 based on PCR or serology, and that's from a total cohort of 69,000 individuals. So you can see it's quite a small population. And this very nice graph shows what a range of symptoms is present, including initial upper respiratory tract. Most children have fever, but then after that, there's a mix of upper respiratory tract symptoms, gastrointestinal, abdominal pain and diarrhea, quite predominant, and then neurological weakness, seizures, and then there was a sort of increasing multi-system type presentation, including cutaneous and cardiovascular manifestations. And this became a worry in terms of multi-system disease and children that were requiring more intensive care. In terms of those children who are more at risk of developing severe illness, and of those 650 children, about 18% required PICU admission based on those that were enrolled to the ASARIC database. The factors that were associated with severe disease included Black ethnicity, and then the young infants and the older children. And only, despite that, only 1% died in the proportion of children for whom outcome data was available. So the important thing is that most children survive. But what was alarming was the sort of reports, especially initially in London, but then globally with particularly clusters that were initially reported in France and New York, of a sort of multi-system inflammatory syndrome called PIMS-TS or MISC. And this is part of my collaborator in Imperial, Michael Levine's group, a Diamond study. They did a report of the clusters of about 58 children that were reported. And what's interesting is this issue of the active infection, both in this study and others from Birmingham and other sites, show that the PCR positivity rate in children with PIMS-TS is quite low, but the majority of them are serology positive, suggesting this is some weeks after acute infection, and that often there is gastrointestinal symptoms, but then this sort of mucocutaneous presentation is similar to Kawasaki disease with a skin rash, conjunctivitis, and importantly, cardiovascular problems, including shock with myocardial dysfunction and need for inotropes, but also coronary artery dilatation and vascular aneurysms. And in some of these children became very severely unwell, requiring ECMO as well. So there was a potential similarity to Kawasaki, but despite that, a low mortality of 2%. And then going back to ASARIC, these were then in the subsequent paper by Olivia Swan, these were sort of pulled together into how do we define this syndrome, distinct in some ways from Kawasaki disease, but also having cutaneous and cardiovascular manifestations, and essentially this paper that Liz Whitaker has done shows very nicely what they did is they had samples from children with PIMS-TS and compared them to previously collected samples from other studies of toxic shock syndrome, as well as samples from San Diego, from Kawasaki research group of children with Kawasaki disease and those with Kawasaki disease shock. And what you can see is that the PIMS-TS children are older, have a very strong pro-inflammatory response compared to the other groups, but also had significantly high levels of troponin and coagulopathy. And then further on, we sort of had the UK Paediatric Intensive Care Society put together a further report looking at children admitted to the UK PICUs, and there were 78 children included, and this was in August. And again, you can see that 47% of those children were from Afro-Caribbean background, and that only 22% were PCR positive at the time of admission, but that the vast majority had IgG serology positive for SARS-CoV-2. So this was particularly interesting, and the sort of longer term impacts of those in terms of their cardiovascular morbidity and ongoing symptoms is something that still isn't well defined. Another important question is, why are most children resilient to severe infection? And this is something where there isn't a huge amount of data, but I'm going to summarise what there is that is known and what we need to sort of understand better. In terms of the viral recognition, there's been a lot of discussion about the age-dependent expression of ACE2, and both in the lung and nasal mucosa. There's a high expression of ACE2, and this study, using human cell atlas data, looked at 10 samples from organ donors of healthy lung, and found that particularly in the type 2 alveolar cells, there was a high expression, relatively high expression of ACE2. And in those ACE2 expressing cells, this is in a single donor, that this was associated with a positive gene ontology enrichment analysis shows that there's a association with viral, the genes expressed are associated with viral response. So this was the ACE2, the AT2 cells are the majority of cells in the lung tissue of these individuals that were ACE2 expressing. There's very little pediatric data. This is a study of 305 individuals, and it's again another retrospective look at nasal brushing samples taken in an asthma study, an asthma biomarker study, looking at gene expression. And what they did is they looked for ACE2 expression and age dependent. And as you can see, that the younger, there is a clear trend in terms of the sort of expression in the nasal mucosa. And this was despite correcting for both gender and asthma status. This remains significant. So there isn't a huge amount of data in terms of lung expression, and the lung presentation of COVID in children is not as prominent, even in the most severely ill, where it's a multi-system presentation that seems to be the main clinical problem. But the story of GI symptoms, particularly preceding the onset of PIMS-TS, is something that appears to be fairly consistent in the children admitted to PICU. And this is an adult study once more. And since a large number of patients are reporting digestive symptoms, this used again human cell atlas data, looking at ACE2 expression in GI tract epithelial cells, and what they found is that the highest expression is in the lower part of the intestine, the small intestine, colon, and rectum, and they looked at expression of both ACE2 and the transmembrane protein receptor for it, and found particularly in the colonocytes and enterocytes a high expression compared to the upper GI tract. There is no data in children, but this small study very early on last year, it feels like last year, at the beginning of 2020, shows that that children, and this is only 10 children, continue to shed into their feces coronavirus up to 3 weeks after their initial presentation. This is basically showing the CT value. So the smaller number of CT values to detect the virus, the more prominent it is in the fecal sample. And what you can see is that while the nasopharyngeal swabs were clearing fairly quickly after admission, the children were continuing to secrete and the virus was continuing to be present or detectable for some weeks after admission. Whether or not there is a significant risk in terms of transmission isn't clear in terms of the infectivity of that virus, but certainly was present. But the CT values are mostly declining to levels that are unlikely to represent a major risk. The other thing that is becoming clear is the longer term impacts, and there's been a lot of interest especially in those who are even not critically ill, of the potential impact on the neurodevelopmental and psychological outcomes of children affected with SARS-CoV-2, and particularly when we look at previous viral epidemics and pandemics. And we see that with paraflu and other types of severe viral infection, that they become severely ill, have polyneuropathy and significant neurological morbidity and weakness afterwards. So this is something where the impact isn't understood, and I know there are some studies planned to follow up the children that have been affected with COVID, both within the community as well as those admitted to hospital, in order to look at the impact on their schooling and return to a good quality of life. In terms of the infection risk, this is looking at how does the CNS infection occur, and it can either be transsynaptic across infected neurons, particularly our entry through the olfactory nerve and the nasal entry of the virus, but also, of course, with systemic inflammation. There could be leukocyte migration across the blood-brain barrier, or infection of vascular endothelium and transmission through the vascular endothelium into the brain endothelium as well. So in terms of outcomes, the problem for children is that most of the children are in the community. And the research that's needed is to look at why most children are resilient, to consider why their pathophysiology is so different, and to establish the longer term outcomes. It's clear that the younger children, particularly those of primary school age, are resilient and seem to be safe in terms of being spreaders of disease, and most likely the burden of disease in that cohort just reflects community burden of disease. But clearly for each site there are very low numbers, and the important issue is enrolling into national and even international studies of both pathophysiology and treatment, as is the case in the UK with both the Isaric genomic and the recovery trial, which all have paediatric representation. So thankfully the vast majority of children survive. I think that long COVID is an issue, particularly we need to be able to identify those children to support them and their families, which is an important thing in paediatrics, and that there's a lot that still needs to be done in children. Thank you very much. Thank you.
Thank you very much indeed. I shall just wait for my co-chair Naz to join me. Thank you. I'd like to introduce another member of the panel here today, which is Margaret Herridge. Professor Margaret Herridge is from the University of Toronto, and she's going to help us to chair a session now, which will be a combination really of, first of all, some specific questions about those fantastic talks, and then we'll move into perhaps a more general debate about the whole COVID situation and where everyone thinks we are going. That really was just a huge amount of information from four incredible speakers, and it's really hard to know where to start with these questions, to be honest. Many of these subjects are interlinked, so hopefully we can get some good discussion going. We have some questions in already that audience members have submitted, so please do continue to put in your questions just to the right of the screen, so we can ask the speakers on your behalf. Perhaps, if I may, I'd like to go back to a small snippet of information that you told us, Sir Stephen, which certainly pricked my ears up and other members of the audience too, which was the fact that you told us that as people get older, and when you looked at this older population, particularly, I think you mentioned the over 80s, the effect of obesity seemed to vanish. And I just wondered if you had any hypotheses as to why this might be.
I think there are two broad reasons. One is that we kind of forget that sometimes the effect of age is so dominant over all other risk factors for doing badly and dying of COVID. So there's a huge effect on age, which swamps other things and gets even greater as you get over 80. So that's one effect. And the second is that there's a kind of obesity survivor phenomenon for people over 80. Weight loss tends to happen naturally over the age of 70, 75. Those people who have managed to remain obese and stay alive over 80 are a rather remarkable group of people, and they're increasingly small in number. So I think it's partly just the gross epidemiology of it that the number of the mortality rates for the over 80s are exceptionally high, and it kind of doesn't matter whether you're thin or fat at that stage because it's so dominant. The age effect is so dominant. Now, I mean, I'm still yet to hear good biological explanations for exactly why that is, because it's fascinating how it's so powerful, but nonetheless it seems to swamp all the other metabolic and other risk factors that we've got at that age, at that time.
Thank you. And maybe just a comment. I don't really know that there's a question attached to it, but I'm sure those of us who all worked on ICU during the first wave of the pandemic, I think would agree that what we saw was something that was quite unfamiliar to us, was just incredibly high, what was probably insulin resistance in type 2 diabetics. We certainly at the Royal Free were using huge amounts of insulin to control people's diabetes. And so it was very interesting to see that cell metabolism paper just mentioned at the end of your talk, sort of implying that there was a mortality risk with high levels of insulin. And I just wondered if you might be able to unpick that for us slightly.
Yeah, I mean, so there's several things going on. I mean, one, I do think that insulin resistance is likely to pick out a subset of people who are going to do badly. So that hyperinsulinemia / insulin resistance is predisposing to doing badly. So those people whose beta cells have declined and have hyperglycemia, they will be the ones who are hard to control because they're insulin resistant. So insulin resistance precedes the worsening. Now, any severe inflammatory condition will cause insulin resistance, particularly if it causes a high activation of the cortisol axis. So any situation of stress, whether you produce tons of cortisol, which you will do in these circumstances, is profoundly inducing of insulin resistance. But you're right. I mean, you see as an intensivist lots of stressed, ill people with diabetes, but there did seem to be a disproportionate number requiring vast amounts of insulin. I don't think we quite figured out why that was. I mean, why the COVID pathology leads to such severe insulin resistance is not entirely clear. I would have a caveat about that Chinese study. I mean, implying that it's infusing insulin is killing people. That was kind of the broad conclusion of that paper. But I think you have to be very careful because those individuals who are worse metabolically are bound to be the ones who you end up using lots of insulin in, and they, etc. So it's confounded from the beginning. I still think the jury's out on what it is about being so sick with SARS-CoV-2 that makes insulin resistance so profound. I don't know the answer to that one.
No, thank you for that. And we see the same sort of confounders when looking at the amount of oxygen you give to patients in ICU, and it's not necessarily the case that those people receiving more are being harmed by it, but they may be the sickest. So it's very difficult to unpick. Naz, shall I hand over to you for a moment?
So there's quite a lot of questions for you, Stephen, but I'll just rotate it around a bit to give the other speakers.
Yeah, sure.
So Kenny, I thought there's one there. Somebody's written saying, well, one issue that we have is choosing which drugs to trial and what combinations are possible, because all speakers have spoken of different drugs to target specific issues. So where do we start with testing combination therapies? And should personalized medicines be considered given your data on genetics?
So it's a really interesting question. So I think prioritizing drugs for clinical trials is the name of the game for basic science and COVID right now. We need to make the right choices about the next drugs to include in trials. And if we get those choices right and find effective treatments, then we'll save tens of thousands of lives. Even now, with the vaccine coming, the disease is still going to be around worldwide for a long time. So, I think everyone on this panel will agree the way to do that is large-scale randomized controlled trials like Recovery and REMAP-CAP. And it's fantastic that we're getting hard answers from both of those trials. We're really making extraordinarily rapid progress, one by one. And I think being pragmatic, the way we're going to get combination therapy is by adding treatments on top of treatments we've shown to be effective, because certainly if I'm treating a patient with COVID right now, I wouldn't randomize them to not receive dexamethasone I don't think, I think you'd have to have a very strong reason for doing that. So now we're looking for additive effects from other therapies on top of dexamethasone. And I think that will continue to be the case. And hopefully, as we get more therapies on board, we'll end up with multiple combinations. But we may never know what the optimal combination is, because we won't have time or the inclination to do randomized controlled trials that don't include the drugs that we already know to work.
And I might just follow up actually with a further question more specifically about the work you presented, your own work. So everybody's very excited because not only have you found some genes, but you've potentially found drug targets. So I think many in the audience will be interested to know, what can you describe on some level that process going from what you've discovered to getting to a point of drugs in that area? Because I think one of the things you did suggest was that there may be drugs that can be repurposed that are already licensed to use.
Yeah, so I mean, there are 3 drugs that are really quite close to being used. So 2 are in use already. Baricitinib. I mean, there was a trial published in the New England Journal last week, reporting a trend towards mortality benefit. So I think that's a very strong candidate. And our genetic data support the use of that drug, although, as I said in my talk, there are caveats. We're never certain that there isn't a mechanism that we don't know about through which a genetic effect is being mediated. Interferon, either inhaled interferon beta, has been tried by Synergen and the Southampton group, is a possibility, and there are some early promising results from very small numbers of people from that therapy. And I mentioned CCR2, so there are CCR2 inhibitors that are available that might directly prevent macrophage or monocyte infiltration into the pulmonary vasculature, as Stephen discussed in his talk. And our genetic data do find, that CCR2 association, which tells us the direction of effect that we would expect based on that data. If there's not another mechanism, the direction of effect would be towards benefit from inhibiting CCR2. But again, the big caveat with that one and from our data is that there are several other genes in the exact same position that are also affected by the expression of them. The amount of the gene that's produced is also affected by the same variants. So we can't tease apart that signal between those genes, and we may never know, because I think in COVID, what we need to do is take the information we have, make informed judgments about it, and get these therapies into trials as fast as possible.
Great, very exciting stuff. I'll hand over to Margaret as another co-chair for the session. Margaret, you're on mute at the minute.
Thank you. Sorry. No matter how many Zoom meetings you have, it seems like there's always someone who forgets they're on mute. So today it's my turn. Sorry about that. Thanks. Thanks very much for the opportunity to join such a distinguished group and to participate in some of the questions. Here's another question. This is for Nazima. A question commenting that it's very interesting that there is a greater GI infection in children, and that many of the symptoms appear to imply involvement of the autonomic nervous system. I would just say that there's a lot of discussion currently, at least in adults, about the autonomic nervous system effects in perhaps some of the long COVID symptomatology as well. But the question is it likely that the virus is being taken up through the vagus nerve and transmitted to the brain? And would really welcome your thoughts on that.
Yeah, thanks very much. That's a really interesting question, particularly in relation to sort of neuronal control of inflammation, given that these are children, the ones that are most sick are the ones with a very much a severe shock type presentation. And of course, the gut-brain, gut-lung axes are not well understood in pediatric critical illness generally. So I think it's very interesting. There's really not enough data on that even in adults, but certainly something that needs looking at.
Mm-hmm. And maybe just while I have you on, here's another question about the children. Maybe if you could expand further on the potential long-term prognosis of children, and in particular in some of the identified high-risk groups. So some of the racialized groups and in particular, maybe, you know, across the age range of children as well.
Yeah. Again, I think it's a very interesting point, which is the fact that it was so marked that it was children of Afro-Caribbean background that were most likely to have severe illness and need intensive care. And what was interesting for us is that those with underlying comorbidity, perhaps they're shielding highly effectively, are not represented so significantly amongst those children with severe COVID compared to our general PICU admissions, where more than 50% are usually have an underlying significant comorbidity. So there are these inborn risk factors. The longer term outcomes, the nature of the disease, which is the problems are twofold. One is most kids are not being admitted, so we need to have a better link with the sort of community management and to follow those children up centrally. But also in terms of the way PICU is structured, it's a hub and spoke. These kids are coming into regional centres and there isn't an infrastructure yet to follow them up. So the long-term impact is likely to exist. And I know there are pressure groups. There was a report on BBC that our department was involved in last couple of weeks ago. And there's a group called Long COVID Kids. So it's quite an active issue, but it's not defined.
Thanks so much. And maybe just before I hand it back to Daniel, I might just comment that I know, I'm sure many members of this panel too have been on many other Zoom meetings. I know I've been involved in some NIH meetings and WHO and ISARC meetings. And just to your point, there's been so much discussion about the social determinants of health, which maybe, you know, this whole pandemic has really helped to highlight in a way that often we don't talk enough about. And it's really shone a real light on that, and how it's just such an effect modifier, a risk modifier across so many different groups internationally, and highlights a lot of deficiencies in the system depending on which country you live in. I don't know if anyone wanted to comment on that, but I think that I don't know, even speaking as a clinical researcher, sometimes we're more or less focused on social determinants. And of course, these are just fundamental constructs. I don't know if anyone else wanted to weigh in on that discussion.
If I may, I'll say something, Steve O'Reilly, here. I totally agree with you. And I think in terms of exposure to the virus particularly and the quality of healthcare, it's really important. It's strange, it probably varies from country to country. In this country, it's almost dominated public discussion to the exclusion of any discussion that there might be biological reasons why, for example, particular ethnicities may be predisposed to have particular pathologies. And that can be dangerous, I think, in some ways, because unless we start thinking about, there might be, you know, why, for example, would children of African or Caribbean origin have particular disease trajectories, and could that relate to complement gene numbers, etc.? I think we really need to have a balanced discussion, and it's become, you know, it's really important, I think, to be able to talk both about the social determinants and possible, you know, in terms of targeted medicines, for example, we need, you know, we may need to target medicines to specific pathological trajectories that you're predisposed to by genetics. So I think it's really important that we have a sort of adult discussion about both of those really important aspects of what's going on in this epidemic.
Thanks, those are great comments.
I think maybe also, Margaret, I'll just say in the UK in particular, I think it's interesting where we know we have a universal healthcare system, no payment has to be handed over, nobody has to have insurance. If we think that intensive care might benefit somebody, they will be admitted. And I think even in the context of that, you still see very clear differences in outcomes based on social determinants still. So I think that whilst I entirely agree with what Stephen's saying as well, that we need to have a balanced discussion about it, I think the fact that this still dominates, even when you have a fair playing field in terms of access. It's very different, obviously, when we think about health literacy and education and knowing how to access matter. But even when it's there as a service, we still have poor outcomes in those who live in more deprived areas.
Yeah, and I would just offer, you know, the Canadian perspective that we have a single party or a single payer system too, but there are clear disparities in health within our system related to race, socioeconomic status, connectedness to the system. You know, you know a doctor, and so you can, you know, have access more readily, as an example. So for sure, the systems aren't perfect. Thanks for those comments. Maybe I'll hand it over now to back to Daniel.
Thank you very much, Margaret. Pratima, I wonder if we could just bring us back to coagulation. And I think that there's a couple of questions I have here. The first one is about our use of low molecular weight heparin on the ICU. And was there any truth in the end, do you think, to the fact that low molecular weight heparin may have been less effective in patients affected by COVID? I think there was a sort of story of low levels of antithrombin 3, for example, and I don't know if we quite got to the bottom of that, and if you followed that story at all.
I mean, I think one of the things that the decreased effectiveness of heparins in patients in intensive care is a generic thing. I don't think it is related to COVID. It's related to the fact that you have got very high VWF, and therefore heparin, which has got a negative charge, can be cleared more rapidly because of the activation of the macrophages and a high VWF. And I think we see that even in the non-COVID situation, which is the reason we have a tendency to monitor patients on intensive care. I think that is the first thing. The second thing is that the low antithrombin, I think we haven't seen that level of low antithrombin. The only time we have seen those levels of antithrombin reported in the literature are the patients on the ECMO circuit, and they have really a consumptive coagulopathy. I mean, remember our patients who were there in intensive care for 5 weeks and 6 weeks, the lowest antithrombin we saw was about 40 to 50. For a low antithrombin to affect the impact of heparins, it must be really around 20 to 30. And that is when we would probably say, yeah, maybe there is a value in replacement, but those are not the levels we were seeing. And I think just to comment is that the other anticoagulant pathways, your protein C and protein S, are also relatively unaffected. We've seen levels of about 50 to 60. Whereas if you have some of your other patients who have an INR of about 1.8, you would see protein C of about 30, a protein S, and an antithrombin of 30. I just wanted to add a quick comment, Dan, in terms of one of the comments was about the combination therapy in terms of how would you add up drugs. I think for us, in terms of coagulation, I think the one thing we have learned is what causes the thrombus is actually, you will need to have a different way of treating the thrombus. So decreasing the inflammation is important, but how do we clear the clot is equally important. And the reason is that because we all know that your fibrin meshwork becomes your scaffold for your fibroblastic response. So I think, and one of the things very early on we felt, at least within the FREE, which is the reason we ended up being the nebulized TPA study, was that you need an antiviral, you need something to dampen the inflammation. But if your patient has escaped both of them and is a situation where there is too much thrombus, whether it's in the alveoli or in the vasculature, the strategy of actually doing an antiviral and dampening the inflammation isn't going to work. And I think you have to have a salvage option. And I think at the moment, we are concentrating upfront in terms of, and that is important, how can we decrease the magnitude of tissue damage because of viral infection, but we are not looking at what are the salvage therapies are we going to offer when patients tip over and are in that place. Then I think they require a different strategy.
Thank you, Pratima. And I think the other thing linked to that is that we saw a lot of different protocols around the country and around the world in terms of prophylactic use of heparin on ICU, and whether we should be upgrading that in some way. And certainly in this country, there there are guidelines that say we should perhaps give double the normal, etc. And I think that all of us are not really sure what to do, to be honest, because we've all witnessed these very high levels of thrombotic episodes. And what do you think the sort of current best advice is, although even if it's not sort of evidence-based, I don't know.
It's a bit challenging. I think the challenge we have is we have a study which is looking at a randomization of prophylactic anticoagulation versus therapeutic anticoagulation. I mean, we are a small department of 4 people, and we had divided across 2 people. Said in March, I was saying everybody needs to be anticoagulated therapeutically because anticoagulation is pretty safe. Why do we even need to think about it? And 2 of my colleagues said, absolutely no, we need to gather the evidence. And I think this is the inherent challenge we have of trying to gather the evidence versus doing a pragmatic protocol. And I think the pragmatic protocol will need to come from a society. Within our own organization at the Free, when I'm on call, sometimes I'm a little bit more, yeah, fine, okay, let's just increase it. If the D-diamonds are going up, if the patient is not looking as if they're doing well, I'm kind of a little bit more generous, whereas my registrars will probably stringently say, this is not the role-free protocol. So I think this is where probably a guidance, a pragmatic acceptance and a guidance from a society saying, we acknowledge all the limitations, but within the limitations, this is a reasonable suggestion. Because if not, you are then, NIHR turns around to you and says, you're not randomizing your patients into XYZ study. And I think that is one of the challenge. And I think, I'm not sure how best we can kind of do that, but you can't go wrong by doing a higher amount of anticoagulation. Whether it is of benefit to the patient is a different question, because if the thrombi, which we firmly believe are inflammatory, and I think there was a paper that was published in Circulation last week, which shows quite an amount of neutrophils within the thrombi, then anticoagulation actually per se is not that valuable. This is something we have learned from the vasculitis patients. Typically, you have your polyarteritis nodosa or other vasculitis patients. We would do a combination of anticoagulation and anti-inflammation, and you just have to sit tight for the clot to resolve by itself. And I think hence my comment, should we be re-looking in terms of what do we do for our patients who have tipped over?
Thank you very much, Pratima. Naz.
Thanks, Dan. Just for those who might have joined us at 5 to the hour, we have run on from the previous session, have some individualized questions, but some general questions as well for the panel. And I'll just open it right up to be very general here. I think this is something all of us have struggled with. So how should frontline clinicians deal with the avalanche of publications, pre-publications, media announcements that have come out? And I maybe actually narrow this down a little bit and think about how do we handle, or how did you handle potentially an announcement which was made in a press conference about a treatment that is now going to be beneficial before even a preprint was available? And then secondly, if you have a preprint available to you, but not the peer-reviewed journal, how do you approach, what happens when the patient's family comes in and says, I want that treatment I heard on the news last night? Anyone?
Naz, perhaps I could start on that as I'll declare a conflict of interest. So I'm on the recovery trial steering committee, and I think it was the first to commit the crime that you've just described. So we had a meeting at which Martin Landry and Peter Horby, the leaders of the trial, reported the results of the dexamethasone analysis that we're all expecting, and it works. And it's an extremely convincing result in a well-conducted randomized trial that certainly across the UK most people were recruiting patients into. So everybody knew the statistical analysis plan, the protocol, and the conduct of the trial. And then we're faced with the question: do we do what you would normally do and write the paper, pull together all the figures, make sure they're pristine, bounce around some co-authors, and then go through peer review? And of course, the very next day, I wanted to be treating my patients with dexamethasone, and if I'd had a loved one who was sick, I would have wanted them to receive it. So I think the only ethical thing to do is to tell people honestly what we had found. I think Peter and Martin wrote a very comprehensive press release that did contain enough data, I think, for people who knew the trial to make a decision about using it. Naz and I discussed this on our unit at the time, and I think we were, clinicians who weren't directly involved in the trial were immediately convinced. And I personally think that obviously that's very unusual that we'll be in a situation where something is that urgent. But on the issue of preprints, I think one of the best things to come out of COVID, there have been lots of advances in the way we do medicine, and I think the broad acceptance of preprint publication is a net positive. It's been the case in mathematics and computing for over a decade, in biology, certainly genomics, for about 5 years. When you are confident that you've found something new and you're ready to report it, you tell the world, and then you go through the period of peer review. And people who are qualified to assess your paper don't need peer review.
Penny, do you think there's any worry about preprints from people publishing before they've really got to the bottom of what they're doing, or perhaps have been a bit rushed? Which is not to say they are, but how as working on the shop floor should we take that sort of information when it's in the preprint stage?
So I think a preprint, I mean, you're able to assess a preprint of a clinical trial, just as well as you can assess a paper. I mean, people don't change their clinical practice just because a paper has been published in a good journal. You read it and you think about it and you discuss it at journal club with your colleagues. That a preprint of a high quality study meets all those criteria. Of course, peer review is still important, certainly for disseminating findings out with our field. The peer review is a nice shortcut to know that something's probably decent work. I was quite surprised by the press response. Our paper came out in Nature last week, and there was quite a enthusiastic response from scientists, but actually we reported it on medRxiv on the 27th of September. And at that point, the whole genetics community certainly saw it, commented on it, came to, accepted it, and it sort of feels like old news to them.
I don't know if anyone else had any comments on the preprint versus publication aspects.
I think it's the way forward. I think it's going to be the way forward for the world.
Right. And I don't know, Margaret, I mean, you're somebody who's published many papers over the years that's influenced many of our practice in intensive care units. I don't know, is there a different view across the pond in Canada about the preprint in clinical research in particular?
Well, I mean, I would really congratulate Kenneth and the group on an amazing study. I'll tell you that I was just in our own unit. It's very interesting, the uptake of the recovery trial. I think that some folks were a bit concerned about the press release and the data, well, just the press release, because it wasn't just the press release, it was the press release in the context of some earlier issues of data needing to be retracted. And there was some discussion about that. Why are we seeing a press release? Why aren't we seeing the paper? Because we all know that some of the high impact journals, they rush to publication, not rush, but they accelerate publication in very important sort of observations or seminal observations like this would have been. So it was interesting. And I think some people were very keen to commit patients to steroids, and other people much more reticent and really wanting to see the publication, drill down on the data, know it had been vetted by peer reviewers. And I'm not, it's hard to know, I'm not sure there's an absolute right or wrong, but I just think it shows again, kind of your priors, right? I mean, how do you view the literature, and what might your concerns be, or what might they not be? But in our own group, I would say here at the Toronto General, we had a lot of discussion about whether this should be kind of our practice going forward after the press release, or whether people should sort of feel free to do what they want to do until the paper was out, and then we could vet it and have a more sort of a more detailed discussion about it. So and for those of us who weren't kind of participants in your study, or knowing, being on the inside of it, right? Like we would be on the inside of maybe some trials that are being done by the Canadian Critical Care Trials Group, because we're site PIs, and we know the people, we know the integrity of the research, all of that. But I guess so it's not really in particular my comments focused on the recovery trial per se, but just in general on this avalanche of data and not knowing really, what to do about it necessarily, and feeling a bit cautious. And I would say our trainees feeling very disillusioned by some of the retractions and saying, what's that about? I mean, how could that even happen? Being kind of a researcher, but also a teacher and mentor in that context, and talking with folks about what your approach is in this rapidly evolving literature. How many papers does it take to convince you that it's a robust finding? Does it take one? Does it take three? Does it take five? Does it take an international, cohort or an RCT? Can it be a national RCT that moves your practice pattern? I think these are like great questions. And anyway, just to give you some reaction to what happened in our own unit, which is a pretty academic unit, and people had very strong feelings, about what we should sort of do in that context. So just to offer those comments for sure.
So Margaret, I was going to hand over to you in a second, but I'll maybe give you a chance to have a look at the questions. I'll maybe just pose a general question whilst you're coming back up to speed again.
Sure.
So there's a general question here that we've all been focusing on COVID infections, while in the general population, people are struggling with sleep, circadian disturbances, reduced physical activity, and increased sedentary behavior. How do we deal with the potential impact of this? Quite a big question.
Yeah.
I think just to sort of add to that, if anyone has any comments, it is whether we think that over and above the sort of what you might call a sort of ICU type syndrome after recovery from hospital, whether we think that COVID has additional effects on top of that, perhaps.
Mm-hmm.
Steve O'Reilly here. I mean, I think he's talking about the effect of social isolation and what's going on with the lockdown on people's health. I mean, I'm very much a non-ITU doctor, non-COVID doctor. In my diabetes clinic, I see almost two distinct groups of people. Some people who, because of the change in their lifestyle with working from home, can take regular exercise every day and are actually fitter and better, in general, better health than they've ever been before, because they have some time to look after themselves. And others, and generally, again, it goes with socioeconomic gradients, others who are much more stressed and with childcare issues and other, which has made their health and their metabolic health much worse. So it's a set of stressors which have differential effects depending on one's social capital, in some ways, of ability and wealth to handle this new way we're living our lives. So it's really had an almost bimodal effect on my patients.
That's really interesting. Okay, so maybe I'll also put this general question out to the panel here. And I think this is very true of many panels and meetings that have been put together, but the meetings now are really populated by experts in different specialties, much like this meeting has. And the question is, to what extent is the lack of cross-disciplinary research a problem? Or has it been a problem or a barrier in understanding COVID? And how has that, what has been the impact of that? And on evaluating treatment, and also just moving the research questions forward. I don't know if anyone wants to talk about that. It's true, we tend to be kind of at our meetings and in our groups and not necessarily cross-disciplinary. And this has helped a lot bring very kind of disparate groups of people together, which is maybe long overdue and maybe a barrier to moving some of these research agendas forward.
Margaret, I'm happy to take that question, partly because I think coagulation kind of came in a little bit late into the entire research agenda. I think there were two things that we picked up. The first is that when the D-dimers were elevated, I think a lot of proposals were put forward in terms of what can be done with regards to anticoagulation. But at that point in time, the focus was on antivirals and how can we decrease the damage, to the point that all of the coagulation bodies across societies across multiple countries had to write an open letter to the WHO saying that they felt that this aspect, which is an important aspect of the pathophysiology, was being ignored. And I think that has now kind of changed. And I think we now have got several trials. So I think there is this acknowledgement across bodies that maybe we need to kind of look, if somebody has raised a valid reason, that we should kind of explore that further before we kind of feel that there needs to be a social movement to get a study open. But I also think that there have been several kind of positive aspects of this interdisciplinary collaboration. I'm not normally involved in intensive care research, and I think we kind of, I think it was a massive moment at the Royal Free. There were so many patients going through the intensive care. We felt that we had to contribute to the entire movement in a small or a big way. And I think we, again, dug into our own experience of rare disorders. And that is how we ended up doing a interventional study with nebulized tissue plasminogen activator. I would never think of doing such a study. I mean, it was not in my line of thinking. It is not my area of interest. But I think the massive kind of requirement and the kind of thing that as we are learning more and more, we kind of went back and asked ourselves, this is a multi-system disorder. This is not an intensive care disorder. This is not an infectious disease disorder. What else can we add to the kind of overarch, I mean, in terms of the understanding of the disorder? And that is how I think we felt that overall, I think interdisciplinary research is kind of getting there, but I think we are still probably not there to kind of agree this is how we should do things.
Mm-hmm. Thanks so much, Fatima.
There's a related question here, which would be useful to perhaps add to this discussion, in that this is the first meeting held jointly by the Physiological Society and the Intensive Care Society, sort of demonstrating the bringing together of clinicians and physiologists for a sole purpose. And the person who's posed the question has asked how we can perhaps make sure that this continues in the future. Aligning scientists and bedside clinicians more closely to tackling things in this way, because I'm sure if we had put this much focus on many other multi-system diseases, we could have solved them, not that we solved COVID, but perhaps solved some of the issues in a much quicker way than we have seen over decades. Yeah. Any perhaps suggestions as how we sort of don't let this model disappear from our shelves for the future?
I would comment very briefly. I think these things work when people enjoy them and derive benefit from participating in them. And you know, for the example of this meeting, I've taken more notes in this one Zoom call than in any other for quite some time. I've learned a great deal from the other speakers, and I thought we were working in a very interdisciplinary way. Compared to how we tackle other problems in critical care before I showed up for this meeting. So I think continuing to do exactly this sort of thing as we get back to normal, hopefully next year, and tackle the problems that bother us year in, year out, like sepsis and flu, tremendous benefits.
Absolutely, because it would be a shame after the coming together of all these people to sort of lose all these connections between different specialties as we have done. And there's another question here about how we might tackle the quite difficult but very important question of personalized medicine even within COVID. We've heard about lots of different treatment strategies that may work for the population as a whole, but how are we ever going to sort of tackle perhaps the individual needs of the patient in front of us with combinations of therapies, etc., whether it's through genetics or metabolic phenotyping or any other sort of tools that we've yet to discover.
So Stephen, I think you're about to comment.
Well, just, I mean, in terms of people with metabolic syndrome, I mean, I definitely think there is real potential in the metabolic community talking to the intensivists, or in terms of thinking about an intervention such as something simple like metformin or a thiazolidine down, in terms of individuals who are identified as being at metabolically high risk of worsening with COVID. I think there's enough rationale to really start thinking about, instead of just simply going down the anti-infective or anti-inflammatory route, but improving the metabolic state of the patient, perhaps in a more imaginative way than simply trying to reduce their blood glucose, would be something that's worth adding to the mix of interventional trials that are being considered by the people in the intensivist community.
Do you think we'll ever reach a sort of fanciful future whereby we can combine things that you do, such as metabolic profiling, and the things that Kenny does, such as genomic profiling, to sort of individualize our patients when the next pandemic hits us?
That's a tough one. I mean, I think delivering, I mean, I have been involved in over my lifetime in discovering 1 or 2 or 3 illnesses where we have actually had targeted therapy, but they are for handfuls of monogenic individuals. It's beautifully satisfying when you can do it. I'd love to do it again, but mostly when we've done it for rare individuals with single gene disorders where we can replace to think that we can jump to the generality of individuals and using genomic risk scores, I think is still a bit fantasy world at the moment. I think genetics can really be really helpful in terms of, just as Kenneth described, in helping to quickly identify and validate a target that then is more rapidly applicable broadly across the piece rather than necessarily. So I think sometimes people confuse a little bit between what genetics can tell you about disease pathogenesis more. So you find it in rare individuals, but it tells you broadly about how the disease is working. And I think that's more where genetics is coming in right now, rather than individually fingerprinting you for a particular therapy.
I would agree completely with that. I think a convergence between Stephen's work and mine could happen in the next couple of weeks, because the adiponectin hypothesis that he proposed during his talk, we probably have the data to at least start to test that. So we could have a go at that. On personalized medicine, I think one thing we've learned from COVID that we all knew in critical care medicine is it really makes a difference if all your patients have the same diagnosis. So we've found an effective therapy for the host response, something we've never done before in critical care medicine, and it's because we had one syndrome.
And Nazma, how do you think we're going to advance things for the pediatric population? Because you mentioned their seemingly great resilience to this disease, but we just don't really understand the secret that they hold.
Yeah, and also I was interested in what you said there, Kenneth, about sort of, the fact that they're all the same, or like sort of presentation in adults, and that's the problem for pediatrics. In terms of the future, I think a good coordinated longer term impact is important, because potentially even those with mild or moderate disease may have significant impact on their developing neurodevelopment. So I think that there are a lot of efforts to establish regional clinics for that.
And just as we have a little bit of time left, but just as we begin to sort of wrap up the session, does anyone really want to comment on how the future might look for COVID in terms of patients on the intensive care unit? Do we think we are there yet, or do we still have a long way to go?
Dan, do you mean in terms of treatment or in terms of the number of cases we present?
Sorry, I was not specific there. In terms of their treatment, I mean, we now know that steroids may be effective in the patients that we manage, and you're identifying possible new targets. So more from a treatment perspective. Sorry.
So I'll comment very briefly. I think we've got something like a third reduction in mortality in the critically ill with steroids. That leaves 2/3 to go, and I expect we'll have diminishing returns. It gets harder and harder the better you get, but I hope that recovery will be a trial that destroys itself, because in the final arm the mortality rate will be so low because everyone's already on effective treatments that we literally never reach enough events to get a result.
That will be a great thing.
I might just bring a comment in there as well. I think obviously this conference is a physiology and ICU conference. I guess the other end of that is thinking in terms of precision medicine and treatments. that there are evidence-based medicine, evidence-based treatments out there already. And often our bigger problem is this other gap of actually how we get it into practice and how do we individualize it for patients and families so that they understand what we're talking about as well. And I guess potentially, I am maybe a bit controversial here, but maybe there's a much greater gain. It's not as exciting in terms of genes, but perhaps there's a much greater gain with concentration on methods there about how we could improve personalized treatments for the individual, which isn't just based on their physiology and genes.
And maybe perhaps I could actually ask one of our chairs, Margaret, just to comment on life beyond intensive care, perhaps. Some of your work is involved in the rehabilitation of these patients post-intensive care, I believe, and what is the horizon looking like for those people?
Yeah, thanks, Daniel. Sorry, I lost my connection there briefly. So sorry, I dropped off of the meeting for a couple of minutes. Maybe I'll answer that second, and maybe I can just offer a comment just about the care in the ICU right now. I would just, these are amazing comments by renowned content experts for sure. I would just offer too, though, that I'm a full-time clinician as well. We're just right now in COVID, though, and a cause of concern, just totally violating a lot of the tenets that we've all worked so hard on to date. And I think one of the things in particular is the excessive use of sedation and paralytics in a way that I personally haven't seen since sort of the beginning of my career. And understanding that the harm related to a population of deeply comatose, critically ill patients, where we've really tried to move the field toward, being much more awake and hopefully much more mobile in the ICU. So in the call to, engage in new therapies and maybe personalized care, each of which or all of which are extremely important, I might also make a call to observe those tenets of care that we've worked so hard to understand and implement in the last couple of decades that everyone seems to have just thrown away in the context of COVID. There are consequences related to this for sure. Maybe that's a good segue into talking about some of the outcomes work. Well, I will say to the panel here, because I'm engaged in doing a lot of follow-up work. We have a Canadian study, and hopefully everyone, there's a big UK study. There are studies all over the world in individual countries, and I think this will be extremely instructive to see how outcomes varied across countries with different ethnicities, different social determinants of health. We were talking about that, different systems, different health policy mandates, et cetera, and to compare and contrast. I would say that following up the ICU cohort in our current CanCove study is very, very reminiscent, I beg your pardon, of looking after the ARDS patients that we followed years ago. They're very, very similar types of patients. I would say that the excessive use of sedation and paralytics and the immobility, the patients are severely disabled, at least the critically ill folks are. And that's a big concern, and we haven't really talked about outcomes here, but that's probably an entirely, a much larger discussion. The cognitive issues are very present. They are in ARDS people as well. And I think we all have seen that there are different injuries to different areas of the nervous system, both central and peripheral. And more rigorous data will help to bear those out. But I think the ICU issues are COVID non-specific and maybe COVID specific. And at the end of the day, it actually might be a little bit tricky to tease out the independent contributors to each, because it does sort of, they're interconnected. You have long stay, complex, super sick, multi-system organ dysfunction patients. they have, you know, a myriad of disabilities at the end of the day, and what's fundamentally attributable to COVID-19 or its attendant treatments or the complicating ventilator-associated pneumonias and necrotizing pneumonias, et cetera, et cetera, et cetera, I think becomes a little bit tricky. So maybe I'll just end with that comment. Thanks, Daniel.
Thank you very much. And I just wondered whether any of the speakers had any more comments. Really, we're approaching time on this, and I do realise it's been a long session, so I'm very grateful that you've all stayed online and contributed to it. Okay. Well, if there are no further comments, I think this is also the close of the meeting now. So first of all, I'd like to thank the speakers for joining us for such excellent talks and for such a great discussion afterwards. And we've got our value for money out of you during this session, and we're very grateful for you for staying on and talking about these more general points related to COVID. Also to thank my fellow panelists, the Intensive Care Society, the Physiological Society, the chairs of this meeting, Mike, Hugh, Susan, and Steve, and of course yourself, the audience, for listening and for contributing with your excellent and thought-provoking questions. So I think that's it from us, unless there are any more comments from the panel or the chairs. So just thank you very much indeed, everybody, and I wish you a good evening.